This animation gives an overview of how general practice is funded in the NHS in England. In the NHS, general practice is usually the first point of contact for people seeking advice and is the gateway to healthcare delivery. There are over 1.3 million GP consultations every day provided free at the point of delivery, taking place in GP surgeries, within the patient's home and, increasingly, online. There is no standard model for how general practice should be organised. GP practices come in many shapes and sizes to suit the needs of the local community. There are single-handed GPs, multi-partner practices operating across localities, and super practices covering much larger geographical areas. The common factor behind each general practice business model is that most of the individual GPs and practice staff are not directly employed by the NHS. General practice has always been an integral part of the NHS family. However, each practice is a standalone business, with a partnership or corporate structure, providing specified healthcare services on a contractual basis to the NHS. How is general practice paid for? The flexible structure of general practice was established in 1948 with the creation of the NHS. The funding mechanisms have evolved to meet the needs of the NHS as we know it today. There are two types of contract used to commission general practice services. The most used is the General Medical Services Contract, which is nationally negotiated between NHS England and GP trade union representatives. It states the core services that a GP practice must provide to people who are registered with the practice. The total funding for all registered patients, called the global sum, pays for the core services and is determined by the NHS annually as part of the national allocation process determined by Parliament. Each practice receives its weighted population share of the global sum based on its registered list size. The process, known as the Carr-Hill formula, assesses the funding required based on the workload drivers, such as demographics and list turnover, and costs drivers, such as geographical price factors and population density. In 2022 to 23, the annual weighted population payment was £99.70 per patient. This is paid to the practice monthly and adjusted quarterly to account for fluctuations in the registered list of patients. In many parts of the country, GP practices have opted out of providing some core services. For example, many practices do not provide out-of-hours services and transfer the responsibility and part of the funding, currently 4.75% of the core funding, to separate out-of-hours providers. The other contract type is the Alternate Provider Medical Services Contract, APMS. It is a more flexible contract that non-GP organisations can hold, for example private, third sector organisations or NHS trusts, and can be used to commission specific services outside of the core contract, for example, services for the homeless or asylum seekers. In 2004, the NHS introduced the Quality and Outcomes Framework to incentivise general practice to adopt good practices and focus the practice's efforts on local and national clinical priorities. The framework uses a system where points are awarded for the delivery of specified activity relating to specified domains, clinical services, public health and quality improvement. Each year, a practice can achieve up to a designated number of points and receives an additional payment based on their weighted registered patient list. In 2022 to 23, for the average-sized practice with 9,374 patients, there were 635 points available, and payment for each point was £207.56. General practices have the option to provide services for their patients that go beyond the basic core services. These are known as enhanced services and can be defined at a local or national level to deliver services to registered patients, such as vaccination or weight management programs. The NHS amends the range and scope of enhanced services each year to deliver current service priorities. In 2019, General Practice created primary care networks using the Enhanced Services Funding Agreement, and these networks continue to expand and develop. Primary care networks are groups of GP practices working closely together, with other healthcare staff and organisations providing integrated services for registered populations of between 30,000 to 50,000. Practices often work through GP federations and increasingly primary care networks to provide other services closer to where people live. For example, by providing a minor injuries clinic to relieve pressure on the local A&E department and near-patient testing to reduce the number of hospital visits. Contracts and funding are negotiated locally directly with practices involved and can be based on price per activity or annual block payments depending on the treatment. In addition to the cost of providing clinical services, there are many other costs relating to running a GP practice. Practices are assessed and reimbursed wholly or partly for many of these costs, including those related to property, IT, locum fees, inspection fees, and clinical waste disposal. In summary, general practice is organised to meet the local needs of a geographical area. The funding models have been developed to support the working arrangements and provide sufficient flexibility to allow different structures to coexist within a common framework, whilst ensuring consistent and high-quality services are available across the country, irrespective of location.